All right, hello and welcome to today's webinar, where we're going to talk about medical review findings in lipid panel reviews. My name is Mary Sue Gardner, and I am a registered nurse on the Provider Outreach and Education Department. And I'm joined today by other members of the Outreach and Education Department, as well as medical review, who will be assisting in the question and answer portion of today's call. On your screen, as well as in your slide deck, is our disclaimer. Basically, our disclaimer says we prepared this education as a tool to assist you, but it's your responsibility to often also know that Medicare laws, rules, and regulations often change. Our presentation today was developed on the most current laws, rules, and regulations as they stand today. However, if CMS changes their mind or changes the regulation tomorrow, it's your responsibility as a provider to make sure you are following those most current laws, rules, and regulations. We're going to provide responses to any questions you have based on the facts given and based on the most current laws, rules, and regulations as they are today. Now, CMS also prohibits you from recording this presentation for profit-making purposes, and since we would not know the nature of which you might be recording or taking screenshots of our presentation, we do ask that you stop if you are doing that, but we are recording it for you, and it will be available within 15 business days on our YouTube Encore page. On the slide, now is a list of acronyms. Medicare's full acronyms. It's like acronym soup. So if I happen to say an acronym that you're not familiar with, I do ask that you refer back to this acronyms list. And if I happen to use one that's not on this list, just go ahead and put it in the chat and ask the question to all panelists, and someone can answer that for you. My objective for today is that you learn about the medical review findings in the lipid panel reviews and how to avoid these findings yourself. We're going to achieve this objective by reviewing the lipid panel coverage, by also discussing the most common review errors and findings in our medical review department. I'm going to provide you with some helpful resources that we have, and I'm also allowing some time for question and answers, so you can ask anything that you are struggling with. So as we move on and we talk about indications for lipid panel, the medical community recognizes lipid testing as appropriate for evaluating atherosclerotic cardiovascular disease. Conditions or diagnoses in which lipid tests may be indicated include things like assessment of patients with atherosclerotic cardiovascular disease, evaluation of primary dyslipidemia, any form of atherosclerotic disease or any disease leading to the formation of atherosclerotic disease. And I know that's a mouthful, but for those of you who are not clinical, atherosclerosis or atherosclerotic disease is actually a chronic inflammatory disease that causes plaques to build up in our arteries. Those plaques cause narrowing, which also of those arteries, which reduces the blood flow. So plaques can be made up of things like cholesterol, calcium, fatty substances, just your general cellular waste, and even fibrin. So as plaques build up, artery walls thicken and stiffen, which really can lead to blood clot formation or even plaque splintering, which can cause blockage of arteries. It can cut off oxygen supply and cause heart attacks or even stroke. So, I just wanted to give a little background information of, some of these words that we happen to use. If you're not a clinical person and you just happen to bill it, what that actually means to you. So other indications as we move on. Diagnostic evaluation of diseases that are associated with altered lipid metabolism. And that includes things like nephrotic syndrome, pancreatitis, hepatic diseases, as well as hypo and hyperthyroidism. Secondary dyslipidemia, including diabetes and disorders of the gastrointestinal absorption, and even chronic renal failure. And finally, signs or symptoms of dyslipidemia. And that includes things like abnormal levels of lipids in the bloodstream. And it can present in ways such as skin deposits, which are like yellowish fat deposits. Sometimes there's eye issues such as gray or white rings called arcus similis around the cornea. There could be heart and circulation issues like chest pain, radiating pain, radiating to the jaw or the arm or even the back, and also dizziness and palpitation. So those could fall under some of the signs and symptoms of dyslipidemia. Additionally, as kind of a follow-up to the initial screening for coronary heart disease, when total cholesterol is determined to be high or borderline high, plus there are 2 or more coronary heart disease risk factors. This slide contains information on what is considered high or borderline high for these levels as well. So again, additional indication is as a follow-up to that initial screening. And here, listed here are what we consider high or borderline high for your levels. Okay, let's move on and talk about monitoring long-term anti-lipid dietary or pharmacologic therapy, which I know, again, is a whole mouthful, but it all makes sense, hopefully, to everyone that's not clinical in the end. So in order to monitor the progress of patients that are on anti-lipid dietary management, so using diet to manage, or pharmacologic, so they're using medication to manage, for the treatment of the elevated blood lipid disorders, including total cholesterol, HDL cholesterol, and LDL cholesterol are things that are all used. Triglycerides may be obtained if the lipid fraction is also elevated, or if the patient is, just put on drugs. For example, thiazide diuretics, beta blockers, estrogens, corticosteroids, tamoxifen. Those are drugs which raise the triglyceride level. So when you're monitoring long-term anti-lipid diet or medication therapy, and when following patients with borderline high total or LDL cholesterols, it may be reasonable to perform the lipid panel annually. So a lipid panel at a yearly interval will usually be adequate for those types of people. While measurements of the serum total cholesterol or a measured LDL should suffice for those interim visits if the patient does not have hypertriglyceridemia. All right, so as we move on, let's talk about monitoring any one component of the panel. Any one component of the panel or measured LDL may be reasonable and necessary in Medicare's eye up to 6 times a year for the first year when monitoring diet or medication therapy. So again, in that first year when you're monitoring the dietary or pharmacological or diet or medication therapy, however you want to say it, any one of those components may be measured up to 6 times a year. More frequent total cholesterol, HDL cholesterol, LDL cholesterol, and triglyceride testing may be indicated for marked elevations or for changes in the anti-lipid therapy due to inadequate initial patient response to either the dietary or the pharmacologic therapy. The LDL cholesterol or total cholesterol may be measured 3 times a year or 3 times a year after our treatment goals are achieved. Electrophoretic or other quantitation of lipoproteins may be indicated if the patient has a primary disorder of lipoid metabolism. So again, I know that's a lot, but all of these indications and all of these timeframes are also listed in our LCD. So as we move on, let's talk about some of the limitations in testing. Routine screening and prophylactic testing for LCD disorders are not covered by Medicare. So again, that's routine screening and prophylactic testing, not covered. While lipid screening may be medically appropriate, Medicare by statute does not pay for it. So lipid testing in an asymptomatic individual is considered to be a screening, regardless of the presence of other risk factors such as family history, tobacco use, etc. So we're looking for these testings to not be just general screening and for symptomology in your patient. Once a diagnosis is established, one of several specific tests are usually adequate for monitoring the course of the disease. Less specific diagnoses, for example, a diagnosis of other chest pain, less specific diagnoses alone do not support medical necessity of these tests. So remember, as we talked about the covered indications, any one component of the panel or the measured LDL may be medically necessary up to 6 times a year, the first year of monitoring the diet or medication therapy. More frequent total cholesterol, HDL, LDL, and triglyceride testing may be indicated for marked elevations or for changes to those therapies due to an inadequate patient response. So the LDL cholesterol, total cholesterol, may be measured 3 times a year annually or 3 times a year after treatment goals have been achieved. So if no dietary or pharmacologic therapy is advised, monitoring is not necessary. So now we're going to switch gears and move on to documentation that is necessary for a successful review. So should you be called upon to submit documentation to support your lipid testing, these next couple slides are going to go over the things that we would expect to see, and I'll give a little bit more information about these. So as we start out, and I'm going to go through as they appear on your screen, signed provider order. The order should list if it's a full panel or if there's individual components to be performed. The progress notes should support the covered condition. There must be a clear indication within the chart of the diagnosis to support the reason for the test or for additional tests. Also, any symptomology that may warrant these tests should be contained in the progress notes or somewhere else in the chart. The primary diagnoses billed, there would be an expectation by us that the progress notes also contain enough documentation to support what the primary diagnoses billed on the Medicare claim is. Other things we need include the current medication list. As we talked about earlier, if there's pharmacologic management that warrants tests, then we need to know what meds, how often, et cetera. If there's any changes to that medication, medication dosages, et cetera. Laboratory test results, past and present. So any current or prior tests within the past year. Keep in mind, when the NCD says a year, that year is the next month after 11 full months have passed from the last test. So if your test was January 2024, then you need to get all the way through December before you can do that test again. So it's not on or after that exact date itself, not on or after 365 days. But if it was January 20th of 2024, you can have it on any date in January 2025. So again, the date itself doesn't matter. It's not 365 days. Also, advanced beneficiary notice of non-coverage, or an ABN, if it's applicable. So if you issued an ABN, you should have done so because you have a reason to believe that Medicare may not cover the test for that person on that day. It should not be routine to issue an ABN because there are time limitations on tests. We all know, as we've gone through already. So providers need to do their due diligence on looking into when the last test was performed and the medical necessity of performing that test for that patient on that day. If the provider has reason to believe that Medicare may not pay for that person to have that test on that day, then they should issue an ABN to the patient. If you do issue an ABN, you need to submit that for review if we happen to, or any Medicare entity that does review, request a review of your documentation. Although we're really not getting into billing lipid panels as this is a clinical webinar, I do want to take a few minutes on this next slide here to discuss a few modifiers that you would be expected to use with billing lipid panels if the situation warrants. So on your screen, as well as in your handout, we're going to talk about the modifier GZ or GA on your claim. So modifiers GZ and GA may be necessary to put on your claim with your lipid panel in the following conditions. So if you issued the patient an ABN because you expected Medicare is going to deny as not medically reasonable and necessary, you would need to put the GA on the claim. That would indicate that the patient knows if Medicare does not pay the service, if Medicare, you have reason to believe Medicare may not pay that service. They know that they're going to be financially liable for that. So in other words, a claim denial will result in beneficiary being liable for the claim. So if you expect Medicare to deny a lipid panel as not medically reasonable and necessary, and you didn't issue the patient ABN, meaning the patient or beneficiary didn't know they would be financially liable if not paid by Medicare, then you should append the GZ modifier to the claim. That way, if the claim does deny, you as the provider are liable. Before we move on, I want to remind you to please consider taking our survey on today's event. We would like to hear from you, about how we're doing in this webinar and what you liked about this webinar and what else you want to potentially learn about in the future, what other kind of education that we can bring to you. So again, Jennifer just put another reminder in the chat about the survey. So let's move on and talk a little bit about the actual review and the review staff and what they look for. Things that the review nurses are going to scour your documentation and look for when we review a claim for lipid panel services. So they're going to look and see, is the diagnosis code billed on the claim indicated as a covered diagnosis code per the NCD? Is there a link, there is going to be a link on your resource page, which will come up in a few slides from now, that I really do want you to make sure that you are aware of and that you look at that NCD and you're aware of the diagnoses and the indications that are, coverable. Other things that we're going to look at. So we're looking for a diagnosis code, and we're looking that the documentation supports that diagnosis code. We're looking for your physician order or some signed physician documentation supporting the intent. So this can be an MD, a DO, or a non-physician practitioner, such as a PA or a nurse practitioner, if that's allowable by your state. Our nurse reviewers are also going to look for documentation, again, to support that covered diagnosis by your practitioner, and that could be mostly included in your physician or non-physician practitioner's progress notes. Does the documentation support the need for a lipid panel test? Again, check this against the NCD requirements that we discussed today. That's what we're going to look for upon review. Are there symptoms documented related to the diagnosis? Generally, we'd find this in the practitioner's progress notes, but it can be documented anywhere within your office documentation. We're going to look for the current medication list. It's important to show what, if any, therapies, medication therapies are being followed. Again, laboratory results, current and previous, to support the testing that you're providing. So per the HIMR and documentation, you should list all lipid panel tests billed to Medicare within the last 12 months prior to the date of service. So that's what we would expect to see if you have tests within the last 12 months, that you submit those for review as well. If one or more lipid panel tests have been performed within a year to your date of service under review, was it to evaluate for diagnostic purposes? So we're going to check and make sure that it's just not a routine screening, that it was done for diagnostic purposes. We're going to look for medical necessity for having the test. Again, is there symptomology? Is there diagnoses? Do we have documented medication or dietary changes that are being made to our treatment plan? And then is the date of service under review to monitor for long-term dietary or pharmacological changes? And do we have borderline or high LDL or total cholesterol levels provided? So we're going to look through your documentation for all of that. If one or more lipid panel tests have been performed within a year to the data service under review, was it to monitor for long-term dietary or pharmacologic changes? Is one thing we're going to, again, look for. Let's see, is the data service under review the only lipid panel test to have been performed within the year? And then again, does that relate back to the monitoring for the dietary or pharmacologic? Again, we talked about medical necessity, but other things that you have to consider and that we're going to look for in your documentation is the test to monitor for non-specific chronic abnormalities of the liver. Is there a history of psoriasis? These are all things that could also cause additional plaque formation and need for testing. Has the patient developed hyperlipidemia or hepatic toxicity and did not respond to conventional therapy? And then we would expect to see what the conventional therapy was, what it was that was tried. Is the test routine or prophylactic testing for a lipid disorder? Again, symptomology are the things we're going to look for. Remember, it's so important to keep in mind that we don't cover routine screening or prophylactic testing for lipid disorders. That's why your documentation really has to support the medical necessity of the service and the clinical rationale for repeating any tests. Without that information, it could look upon review that the tests are just being done routinely. Remember, diagnostic services like blood tests are covered by Medicare Part B. Cardiovascular screening through a lipid panel does qualify for Medicare coverage every 5 years. However, that is different than what I am talking about today with the identification of diagnostic lipids. All right. So as we move on, let's talk about some of the most common review findings. So we've made it to the errors portion of today's webinar. So the most common things we see are exceeding frequency limitations, no supporting medical necessity for the service, and then lipid panels that look like they're for routine screening. One thing I want you to keep in mind, a denial is a denial. And if you continue to rack up lots of denials, even if they're, automated denials that were done without medical review because your billing didn't match up, you are subjecting yourself to more medical review possibly. So refusal to change your practices, especially after we've told you you're doing something wrong, is landing you in a potential fraud and abuse category. You may be thinking, oh, it's just a minimal charge for that. We'll just take the denial and write it off. But it's an error, and an error is an error. And that's why we want to help you document and report things correctly the first time. So let's move on and talk about some of these errors. One of the most common errors our medical review nurses see during lipid panel reviews is the exceeding of frequency of testing. So this one's pretty straightforward. As I mentioned before, and let's review again, Medicare covers diagnostic lipid panels annually when monitoring long-term dietary or medication therapy, and when following patients with borderline high total or LDL cholesterol. Any one component of the panel or measured LDL may be medically necessary up to 6 times a year, the first year when monitoring diet and medication therapy. the LDL cholesterol or total cholesterol may be measured 3 times a year after your treatment goals are achieved. So repeat testing outside of these parameters may not be paid by Medicare. Remember, if you have reason to believe Medicare won't cover because you're outside these parameters, then you should explain this to your patient and issue an ABN and allow them the opportunity to say yes or no they want the test performed and know that they could potentially be financially liable. So the next issue, documentation doesn't support medical necessity. So there's no explanation for the lipid panel test. You need to support the medical necessity within your documentation. So we know it's not just routine screening. What are you monitoring and what is the reason? This includes what is the diagnosis. Also under medical necessity is things like lacking explanation or not meeting medical necessity requirements as they're outlined in the NCD. And I know I'm repeating myself here, but we need to see why the provider is doing the panel or any one component of the panel. So what, again, is that clinical rationale? Very often we receive a list of labs or an order for a lab panel with a diagnosis, and there's no other information to support that lab test. We don't need a novel, but it does have to be documented, and we do need to see, the clinical rationale supporting the reason for that test. A short statement that supports the provider rationale for ordering a lipid panel would be something that would help, in what we're looking for. So moving on, our final common error is providing lipid panel testing for routine screening purposes and doing that multiple times a year in a single year. And that is just something Medicare does not cover. I want to note, however, when it comes to routine screening, we have seen some misuse and exceeding frequency and the use of the ABN to cover that. This is something our review nurses see from time to time. So we did want to mention that today. In our reviews, we've seen providers doing lipid panels at higher frequencies than allowed by Medicare, and then providing the beneficiary receiving the lab with an ABN just routinely. Once that form is signed and the beneficiary is then liable for the payment, but it has to be explained to them on why. And you have to have the indication. If you are just routinely testing outside the parameters of coverage for no other reason than to just routinely test and make that beneficiary liable, you're not following the Medicare indications for testing. Now, granted, your beneficiaries may be willing to pay out of pocket for those expenses, but again, when we review, we're going to be looking for the medical necessity of having the test done. Many times patients will not question a healthcare provider if they're told they need a certain test or laboratory done. So for lipid panels, please do not bypass the Medicare frequency limitations just by routinely doing screening and routinely issuing ABN forms unless it's really truly medically necessary for that beneficiary. If that's the case, you would need to provide detailed documentation to support the indication, the clinical rationale for the lipid panel or those single components beyond Medicare's limit, and issue your ABN and bill the Medicare, append your GA modifier, and if it comes up for review, then you should have the documentation necessary to support it. I want to also, before we kind of wrap up, talk about one issue that I don't have in your slide deck. But we are seeing a huge increase in denials for no documentation received. So not submitting documentation within the 45 days in which we requested it. We issued the ADR notice. You have 45 days to respond. Again, not responding because you're just going to do a write-off is not okay. When you agreed to be a Medicare provider, you also agreed to submit documentation for review if requested by a review entity. So an error is still an error. So ignoring our request for documentation, we keep track of those things. And the more error you have, the more likelihood that we're going to scrutinize you more. So please do not ignore requests for documentation, whether the claim is for $3, $3,000, $300,000. We still expect you, and you still have an obligation, and you agreed to that when you agreed to become a Medicare provider, to submit that documentation for review. A denial for not submitting documentation is a silly denial, you know, in my eyes. It's not appealable. You'll never get that money back or get that money unless you submit the documentation for review. All right, so on your screen are some resources that I encourage you to go take a look at. This is going to take you to the MCD database for the actual NCD on lipid panel testing. So that is 190.23. And then we have some medical review guides and resources for lipid panels, information on our website as well. And this link will take you right there. So let's recap before we move on to questions. We had a mouthful of information today. We learned about the medical review findings and lipid panel reviews. We also achieved you learning about these by going over some of the coverage requirements to help you better understand why the errors are potential errors. So we looked at those common review errors, we went through a couple helpful resources, and now we're going to move on to the open question and answer portion of today's call. So I'm going to pause here and ask my associate Jennifer if we've had any questions that have come in.
Yes, Mary Sue, we've had two questions. The first one asked, sometimes outpatient lab receives requisition orders from an outside clinic or doctor office not affiliated with our hospital. The lab order requisition with test order and diagnosis is all that is received. Should the lab department request a progress note along with the lab requisition?
Okay, so if you are the lab, the lab requisition, I'm just kind of going to look through, think through this again, orders from outside clinic or doctor. So basically, if the testing entity is the one that is billing Medicare, if you are called upon to submit documentation for medical review, then you would need to get that information. So know that that exists. You do not need to, unless you want to, within your facility, make it a mandate to always have that information, but please know that you should let those outside entities that send to you know that if you ever happen to be called upon for medical review of this lab service or any lab service, they will have to provide you with additional documentation for you to complete that lab review, which may include things like progress notes, medication lists, etc.
Okay, the next question is, if a patient does not meet medical necessity, but wants to be screened, can the ABNs be used?
Yes, Karen, you could issue an ABN, but know that there is some screening, you know, and I believe I said that comes at like every 5-year interval, and that falls under the cardiovascular screening that a patient would qualify for. So if it's the case of, you know, the patient just wants to be screened, it gets into kind of a tricky situation, because really an ABN is when you have reason to believe that today that patient would not qualify. It sounds like in this case you have reason to believe that normally a patient that's on therapy or, you know, has a diagnosis that meets can have lipid testing. But in this case, for this beneficiary on this day, they're probably not going to qualify. So then the answer to that is yes, issue it, noting that they're going to be financially liable, and then you can proceed with the test.
And that was our last question in the chat.
Perfect. So in the interest of time, I'm going to move on, and if you have a question, go ahead and place that into the chat. We'll pause again right at the end. So I do want to make you aware of a National Provider Enrollment Conference that's being held August 28th and 29th in San Diego, California. So CMS, along with Noridian Health Solutions, is offering a free go-to event on provider enrollment. So at this event, you can take advantage of the opportunity to meet with CMS and MAC contractors on provider enrollment topics. Things like how to maintain compliance with enrollment requirements, what do you do if you're new to Medicare, if you're going to be enrolling as a DME, et cetera. And again, it's free. So if you have time at the end of this month to go to a free event in San Diego, California, this might be a good opportunity for you. You can register from this on your slide deck, or you can also register from our live event. So I just looked over at the chat and I don't see anything else in there. So on behalf of myself, Jennifer, all of Provider Outreach and Education and Medical Review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.